Good morning, good afternoon, good evening, depending on where you're joining us from across the world. Welcome to the Africa CDC's weekly press briefing on health emergency across the continent of Africa. This platform is set up to facilitate weekly engagement with members of the media to provide updates on key health issues on the continent, particularly health emergencies that are affecting several member states at this critical time, including cholera, mpox, Marburg, and many others. Today, we have with us Dr. Toba Yenswa, the Director of Pandemic Prevention, Preparedness, and Response at Africa CDC. And Dr. Yenswa is joined by our usual host, Professor Yap Boom II, who is the Deputy Head of the Incident Management Support Team, the IMST. As you know, is a continental mechanism that responds jointly to health emergencies on the continent. Our two principals will dive into the issues around health emergencies on the continent, the current status of response to different health emergencies in many parts of the continent, and also issues around the health security and sovereignty of Africa. As usual, our briefing is also simultaneously being translated in French. You can use the French icon on the Zoom platform to get the French language if you prefer. My name is Nico Wongwe. I'm sitting in for your usual moderator this week. Now let me call in Dr. Yenswa to open our section before we dive further. Prof. Director, it's over to you. Thank you.
Thank you. It is indeed privileged. Thank you for the intro, Nika Wangor, for the great opening and presentation. It is indeed again a pleasure. Good evening, good afternoon, good morning, where you are and where you find yourselves. We, at this time, privileged to present to you the weekly press briefing on behalf of our Director General, His Excellency, Dr. Jean Kashir, who would have loved to be here to do it today, but for other pressing engagement, to take you through what has happened on our beautiful continent of Africa when it comes to pandemic preparedness, response, recovery, and all of the outbreak issues on the continent of Africa. Our colleague, Professor Yap, and other colleagues within the Africa CDC technical team are available to provide you with the details, the technical expertise, and what is happening on the continent. And our role is to make sure that we provide life, we make sure that we prevent deaths and sicknesses due to epidemic diseases. So thank you and welcome.
Thank you,
I will now turn over to Yap to take us through the slides, and we do that jointly.
Thank you so much, Director, for giving me the floor, and welcome, our Director, to this weekly opportunity that we have with our journalists. It's really our opportunity to be transparent, but also to be accountable. As you will see with the question, they make sure that we are made to what we mentioned. So now we'll go to the presentation that I will start on the situation on the health security and how do we move with our agenda of health security. So this one I will give back to our director to comment on the first overview before I go on the technical presentation. Over to you, Director.
Thank you, for that. Now, colleagues, listeners, this is a very, very important issue for me, to our Director General, and our organization itself. We have been, Africa CDC transitioned from the new public health order and transitioned to Africa health security and sovereignty. And by doing this, our DG, Jean Kashir, is very, very much intention to make sure that African countries have the sovereignty, transparency, equity when it comes to disease control and prevention. Over the week, he had an interview with Radio France International. There is this lingering issue regarding data sharing, data ownership, pathogen sharing, specimen sharing, and all of that. And people have been asking, what is the Africa CDC's position? Africa's health security reshaping global health partnership. How are we dealing with our partners? So the DG, the post-USAID saga, you know that, the America First agenda, bilateral health deals. So this interview was granted by him on Radio France International. And I will do a quotation here, quote, "We will no longer accept that partners come and impose their conditions. Bilateral cooperation is good, but an integrated regional approach is better." And in that interview, the first thing that he looked at was, let's look at post-USAID bilateral deals. And what that meant was, the journalist from Radio France International wanted to know, following USAID's, this Matterman, as we call it, 20 African countries signed new bilateral health agreements under President Trump's America First strategy. US funds no longer go directly to African governments, and the model Africa CDC have proposed. Africa CDC want to leverage this to pressure member states to increase domestic co-financing. And that's one of the things that DG Cashier have been preaching, to make sure that member states invest into their healthcare. We all know by now in global health and for Africa, African leaders committed to the Abuja Declaration in 2001, about 15%. So what we try to do at Africa CDC is to make sure that African governments invest resources into that. And point number two that our DG stress was that pathogen and data sovereignty. The US demands pathogens and health data sharing as a condition for new deals, as a condition for giving aid to African countries. So Africa CDC insists on this being transparent. We must do it transparently, equitable distribution, and benefit sharing. We also know that WHO recently signed the pandemic agreement, and there's a pathogen sharing benefits agreement of Annex 12 that we are grappling with right now. How should African countries approach these things? And Africa CDC is leading in this area. Our legal team is leading in this area. We have an example. The unprecedented Ebola outbreak on the West African continent, in West Africa, West African region, especially affecting 3 countries, my own country, Liberia, Guinea, and Sierra Leone. I was at the forefront of that outbreak as incident manager, the 2014-2016 outbreak. And we noticed pathogen sharing, data sharing was an issue. Through that effort, we developed Ebola vaccines, as you are aware, and some of the vaccines are being used right now. Even before the vaccines were developed, thousands and thousands of people died in the region. That outbreak saw the death of about 11,000 people and 28,000 cases. So equity is something that our DG has stressed over and over again, and Africa CDC's model operandi. Sovereignty versus conditionalities. Putting up conditions before countries can before you give resources to country. One example is Zambia and Zimbabwe denounced, unbalanced agreements. Zambia's health deal tied to mineral sector concession, and DG spoke about this during the interview that he had with Radio France International, and demands partners respect sovereignty decision making. No economic blackmail should push any country to do what they are not supposed to do. And so our goal is, in as much as we support partnership, we support interconnectedness, because outbreak response, the world now is interconnected. So no one country should impose on the other by what they don't agree to. And we support countries' sovereignty to make their own decisions on the health of their people. So he said, no international partnership replaces the reforms Africa must carry on itself. We should take our own destinies in our own hands and invest resources to places that protect the health of the continent so that we can have a healthy continent. Domestic resources mobilization was the four category area, or most important area that the DG spoke about that we want our audience to know today. You said cut fundings, prove Africa can rely on its own ingenuity to increase resources. I know government took on the responsibility and took the responsibility when USAID cut funding to invest into their own national budgets and increase financing to health. And this is encouraged. So partners must align with Africa's agenda and not reverse those agenda. Your national plans should be respected. National budgets and political will are non-negotiable when it comes to some of these things that you are negotiating. Benefit sharing should be very much important. When an outbreak occurs, you should make that some of your specimens, your pathogens, your data, those are backings that will benefit African country. And he spoke about regional over bilateral approaches. We cannot work in silos. Regional approaches, example with the Mpox outbreak that is on the continent right now, but winding down. Ebola and Marburg prove a pandemic cannot be managed by bilateral deals alone. Epidemics have no border. The world is interconnected. Right now, if an outbreak occurs in one part of the world, it takes a couple of days for the other part of the world to be affected. And so Africa CDC is actively in dialogue with the US government to shift towards integrated continental coordination. In as much as bilateral engagements are good, bilateral relationships are good, G to G, government to government initiatives is important, but Africa CDC is advocating to dialogue with regional cooperation because bilateral cooperation is good, but a regional approach is better to move our continent forward to engage with the other part of the world and provide healthcare for all of our people. An outbreak elsewhere affect the other part of the world. Over to you, Professor Yap.
Thank you so much, Director, for this overview. And following that, our DJ has continued some engagement, still moving forward our new vision of Africa health, security, and sovereignty. So he met the President Emerson Mnangagwa of Zimbabwe, and they emphasized first, commend the country for the effort on the intersection of climate change and health as we move the continent forward. But it was also the opportunity to strongly reaffirm the support to Zimbabwe. As you will see later, they have been facing quite a number of challenges, but also the effort they are putting in really advancing health security and sovereignty, including the progress on sustainable health financing and local manufacturing. Next slide. We welcome the Ambassador Selma Malika Adadi, who is the Deputy Chairperson of the African Union Commission, as an opportunity to strengthen not only our vision, but the partnership that we are having with the different organs of the Africa CDC and the AUC. Just to emphasize that last week we mentioned to you that we were having that mission in Madagascar, and that was done together with the African Union Commission, the AHSS, and Africa CDC. Just highlighting how this collaboration is essential to reinforce Africa health security. Next slide. While being in Kenya, this has been the opportunity to move our agenda at the political level, but also at the technical level, as you will see. So our Director General has engaged His Excellency Honorable Aden Duale, who is the Cabinet Secretary for Health in Kenya. And you know the role that Kenya is having in the continent on moving forward the agenda of local manufacturing, having in mind that the next committee will happen before the Q2, when we'll have that big conference, that summit on local manufacturing. So here, the discussion emphasized advancing health security, resilient health system, and universal health coverage. So the DJ really commend Kenya's commitment to improving health and well-being, reaffirming Africa CDC continued partnership. Next slide. So while still being in Kenya, DG has the opportunity to deliver the keynote during the Maternal, Newborn, and Child Conference, the IMCH 2026. The first statement: nearly 178,000 mothers and 1 million newborns die annually in the continent, mostly for preventable cause, which is at this point not acceptable. So the message was really to emphasize, to engage countries that need to accelerate the progress, including strong health system, sustainable financing, and innovation. Health justice, development, and sovereignty issue reaffirm that Africa must lead and deliver. That was the key message, and the conference continued bringing all experts, finding new solutions on how we can reduce the burden of maternal and child mortality. Next slide. As mentioned last week, we promised you that this week we will be having our DJ and the Minister of Health of DRC to appreciate and to explain actually the transition that is happening in DRC, which is reaching the historic 14.5% Abuja target for health sovereignty. So what is happening as we do speak now, the president of DRC, President Tshisekedi, is engaging the governor of the different region and province of DRC. And one of the key this conversation happening is how this domestic financing is going to support the health, so that it's not only at the national level, but it's also decentralized. Next slide. Last Monday and Tuesday, there was a regional meeting on public health emergency preparedness and response that happened in Malabo. It was really the opportunity, one, to appreciate the strong leadership of the government of Equatorial Guinea by the Minister Honorable Mitoa Ondoa on supporting the coordination and collaboration of public health emergency operating system. So it was the opportunity to launch a regional technical working group on public health emergency operating center, in French, GTTR COUSP, which will provide a platform where the different countries, the 9 countries that were represented, will emphasize the regional coordination, but also strengthen the center of excellence. This is an opportunity to strengthen the capacity, knowing that this region is quite prone to emergency. You've seen and you will see what is happening in DRC among other countries. But it's also the opportunity to bring together the different experts within the region so that they can support countries depending on the needs, but also depending on the availability of the human resource. Last but not the least, and quite emphasized, is the need to strengthen the resource mobilization by looking at financing strategy, which include domestic investment, as I mentioned previously, as what we are seeing currently in DRC. Next slide. On the other side, still in the same Central Africa, in Burundi, the strengthening of capacity building that I've just mentioned was happening with the African Voluntary Health Corps, the AVOC. A week ago, you were asking us how Africa CDC is supporting the response in many countries, and we mentioned the capacity building, so we take advantage of this to remind you what the AVOC is. So the AVOC was established by the Assembly decision of the African Union to really safeguard Africa's health. So the training need assessment is the first part, to see what are the needs in different countries. What are the different profiles? Is it in epidemiology? Is it in communication? Is it in IPC? Is it in what? Based on that, they make a curriculum which is competency-based training, where we have one, the adaptive and relational, which are the soft skills. Two, we have the professional competency. And three, of course, we have the leadership and management. So the first part is the induction that was happening in Burundi, in Bujumbura. Next slide. So for this 12 model, we have participants coming from 18 French-speaking countries with 72 participants for the central region. If you recall, a month ago, we were highlighting what did happen in Ghana and in Uganda. So now we have the target of 400, that is 22 target, and to date, we've managed to train 302. So we are moving forward to provide to the continent the capacity to respond within the 48 hours, having the right expertise to deliver. So the expected outcome that we see is to have a professional knowledge and ethics, a good understanding of Africa CDC, policy and process mastery, operational readiness, and stakeholder collaboration. This is what we expect to our AVOC. Then when they will be deployed, they will have all what is needed to integrate themselves at the national level, but some of them can move from one country to another, depending on the resource that are needed. Next slide. So here we hand over back to Director Tolbert to emphasize the overview of the public health event in the continent. Over to you, Director.
Thank you. Thank you. Great opportunity. Now, our slogan, safeguarding Africa's health. To safeguard Africa's health, we should know exactly what is happening in every African country through our network of emergency operations centers, people who are doing surveillance in the counties and reporting back to Africa CDC. So by Public Health Week 12 or Epidemiological Week 12 of 2026, which 12 is from the 22nd of March to the 28th of March. So this information is so real time to know what is happening on the continent. And we measure that based on moderate to high risk events that happening on the continent, high risk and low risk and moderate events that are happening, and diseases that are top diseases that put risks to the population. So if you see this, you will look at the overview of public health events based on the data we've collected by pathogens, that is diseases, and then by reporting member states, suspected cases that we follow, those that are confirmed, and people that unfortunately die from the diseases. So this is one of the key functions of the Africa CDC's role on the continent. And our DG always said that epidemic preparedness and response is the DNA of the Africa CDC, because we want to know what is happening in as much as we have other things going on, primary healthcare, science, research, and colleagues are online right now to provide some of those things. So for cholera outbreak on the continent, about 14 member states reported, and suspected cases of about 20,000 cases, confirmed cases were 6,000, and deaths, unfortunately, all cases of death were 514,000. And we monitor outbreak of measles on the continent as well. 17 countries, member states reported 51,000 suspected cases. Out of that, 1,000 have been confirmed and 385 deaths. You are aware now that Mpox is one of the priority diseases, and it was the first time that the Director General of Africa CDC declared public health emergency of continental concern, continental security, and because of the authority that was given to Africa CDC to do this. So Mpox, right now, the cases are decreasing according to our data, but it's still an issue in other countries. But 22 countries reported 13,000 suspected cases, about 2,000 confirmed cases, and 125 deaths as of epidemiological week 12. Then Lassa fever, we're following Lassa fever closely. You know, the West African belt West Africa is Lassa fever belt. You look at countries like Nigeria, Liberia, Sierra Leone. These are the areas that, as we speak, in fact, there are research going on there to have vaccines prepared with some of our partners, and our science team is monitoring. And diphtheria is one of the diseases that we are monitoring, and 3 countries reported 1,154 cases, 361 confirmed, and 38 deaths. For now, this is it. And we also comparing what happened in 2025 and what is happening now in 2026. It's still early. We are just in the epi week 12. We have to go up to epi week 50 something. So closely, our epidemiological team is working very hard to collate, and we ask African countries out of the 50 some more countries on the continent. This number that we're getting right now is many, so we need to do more for our countries on the continent to report. Because when we know we don't want to be blindfolded when an outbreak occurs somewhere we don't have the information to respond. Our work is to make sure that we look at the data and see which areas are trouble areas with the pathogens and diseases that we are dealing with. We don't want huge casualty like what happened with COVID-19 and Ebola and other diseases, measles that we are following in Sudan, measles cases that we are following in DRC, cholera cases, and all of these that are killing people on the continent. Over to you, Yap.
Thank you so much, Director Tolber, for this overview. So we'll go a bit deep on what we've seen in the continent. Next slide. And what we've seen, starting by what you highlighted, the second cause of case that we are seeing is measles. Measles that we are seeing really surging and increasing in DRC, and going back, as I mentioned, with the issue of Central African region, where we will see quite a number of those outbreaks. So as we do speak now, we have all the provinces that has been affected, 364 deaths with a case fatality ratio of 1%. So this outbreak, as you will see, the distribution in terms of age is mainly the population between 12 to 59 months, 55%, which also emphasizing the challenge of vaccination. When you go to the vaccination, you will see that in 2024, only 55% of the target population have been vaccinated, which explains why we have the occurrence of those ones. But it's important to emphasize the challenges to reach some of those kids because of the situation we are talking about, the North Kivu, South Kivu, where the access is quite a big challenge. You also talk about the overcrowded camps with poor sanitation and IDP camps. So those are structural barriers for the vaccination and therefore allow the occurrence of those outbreaks. However, the country is responding with the planned integrated measles rubella vaccination, which will move aligned with the polio campaign, sometimes in the end of this month toward mid-April, but also strengthen the risk communication and community engagement. Next slide. Going to the issue of Mpox, where we are really moving really deep into the transition where countries are the one managing the Mpox. So at this point, we have Madagascar, DRC, Kenya, and Burundi that contribute 82% of the case. But really, we appreciate the 90% decline that we have been seeing since the last 6 weeks. So the transition is continuing, as we will be seeing in the next slide. Madagascar, where we were last week and where our team is still working very hard with the member state and the other partners on focusing on the hotspot, those districts that provide 80% of the case. That's where the intensification is going to happen in terms of integration with the surveillance, the risk communication and community engagement, and the vaccination. Always to emphasize that the country have started the vaccination with the first-on workers, but this week they actually started with the key population and vulnerable population using a strong integration of the CSO. So on top of that, they all continue the decentralization of the laboratory, and we believe that the intensification with the community health workers who will be deployed on the hotspot will affect the test positivity rate. As you can see here, we are still at 73%, which means that 7 out of 10 people who are positive are the ones coming by themselves to the health facility, which means the bulk of the case remain in the community. That's why it's critical to accelerate the deployment of the community healthcare workers. Next slide. Talking about the vaccination, so as I mentioned, those are the regions that were the first to be targeted because they are the hotspot, but also to emphasize the flexibility that the country has taken, one, in the deployment of the vaccine, but also on ensuring that the key population receive the vaccine within the site where they are comfortable, avoiding stigmatization. And this is very commendable with the integration of the CSO on the vaccination, on the risk communication and engagement that we have been seeing in Madagascar. Next slide. Now in Kenya, we've seen since last week a decrease of the number of cases, but still we are challenged when we see test positivity rate of 62%, which also highlights the fact that the surveillance is not active as it should be and as it was at some point. However, the country is meeting today, the NITAG, so that they can approve the next round for the vaccination. Remember, what is recommended and what they will do is to have an integrated approach where the surveillance will move together with the vaccination so that we can have the best efficiency of our vaccine. So far we have 38 counties out of the 47 that has been affected, and the case fatality ratio of 1.7% for the 19 people who have died out of the 1,087 confirmed cases. Next slide. Moving toward the vaccination, we keep on moving. Just as a reminder, in August 2024, the continent was expected to have not more than 20,000 doses of vaccine available. Through the advocacy, through the political engagement, now we have reached the 5 million doses that has been delivered to 17 countries. And we have almost 3 million people, 2,095,000, that has been vaccinated with at least one dose of the Mpox vaccine. We have 2 countries, Cameroon and Comoros, who will be receiving the vaccine, the Cameroon on the 29th and Comoros on the 31st, respectively. Next slide. From Mpox, we move to cholera, where the continent represents 59% of the global cholera case, but 99% of the global deaths are happening in the continent, which strongly highlight the challenge that we have in terms of the case management, but also in terms of getting our patient on time and in the community. As per now, we still have DRC and Mozambique that contribute to 83% of all the cases and 86% of the deaths in 2026. We have some good news, however, Kenya, Sudan, and Tanzania that have declared the end of the outbreak this year, while we have Rwanda and Zimbabwe that have declared new outbreak. Next slide. So when we see the evolution for the last 6 weeks, we can see that Zimbabwe, though the number of cases remain still low, have seen an important increase by more than 300%, while Zambia continued to increase of 84%. So we see that we have been having 321 confirmed cases in the last 6 weeks. We have other countries, Angola, DRC, Mozambique, South Sudan, Burundi, Malawi, and Somalia that have seen some decrease. And as mentioned, Kenya, Tanzania, and Sudan have ended the cholera outbreak. So they will now move within the next 3 months to have the after action review so that they can see what are the lessons learned. And within those lessons, we already anticipate that, yes, it's good to stop the outbreak, but the long-term gain toward the elimination needs some multisectoral approach, which I will mention in the coming slide. Next slide. Once again, DRC is really having the bulk of the case, with 20 out of 26 provinces that are being affected, a case fatality ratio of 2.79%. You can see that the number of cases have slightly increased, from 1,294 last week to 1,260 this week, with also the number of deaths, which on the other side have decreased. So the challenge that is being faced, one is the poor wash in the IDP camps, two, the seasonal flooding that with the heavy rain that are contaminating the major water source. In terms of response, vaccine play a key role. We appreciate that the volume of vaccine available in terms of production at the global level have increased, therefore allowing the country to have the preventive vaccination and the reactive vaccination as well. So the country DRC has made the request, and therefore they are moving toward the preventive vaccination based on the stock that are available, but also some reactive vaccination in the zone de santé of Kinshasa, which is Limete and Kalamu, but also preparing moving to Kampemba, Kilula, and Manica. Next slide. In Mozambique, we are still in that second round of the number of cases, though we have a slight decrease that we can appreciate, especially in the reduction on number of deaths from 6 last week to 0 that we've been seeing this week, for a total of 125 deaths so far, a case fatality ratio of 1%. So now, what is critical to emphasize is what is happening. Going back toward the issue of vaccination, where the country will do the preventive vaccination, just to remind ourselves, the preventive vaccination is the one where 2 doses are available, provided to the population, and giving an immunity that will last 3 to 5 years. While the reactive vaccination that is currently ongoing is really to stop the spreading of cholera. But now, looking forward, the reactive is the most critical because it will give time to countries to really invest in infrastructure to increase the access to water, because cholera is not solved from the medical part only, but really need that multisectoral approach to ensure the access to quality water. Next slide. In Angola, we are monitoring very firmly the Angola, because you remember the country have been seeing those 2 waves, and now we see some small increase in the number of cases that has been happening recently. So for that, the country is really intensifying the surveillance to really control the outbreak, but also the scale up of the wash, because the main challenge is that roughly 44% of the population have access to safe drinking water, and only about 55% have adequate sanitation. Next slide. In Zambia as well, we have this wave that is continuing with an increased number of cases from 75 last week to 106. We have 8 out of the 10 provinces that have been affected, with a case fatality ratio a bit high of 1.6%. So the driver in Zambia are the contaminated water source, but also the weak healthcare system and the urbanization and infrastructure gap and poor sanitation. This, once again, we always take advantage on emphasizing the need for that multi-sectorial approach, where the Minister of Plan, the Minister of Wash will strengthen the access to water, which is critically needed in Zambia. Next slide. Now, I will hand it over to Director Tolbert to make the summary of the situation in the continent.
My brother, thank you, Professor Yap. So, members of the press, our listeners, colleagues, the highlights on the continent for this week: Africa CDC had very, very high-level meetings, engagements with the AU leadership. The Africa CDC is an organ and the agency of the African Union. The DG was in Zimbabwe, Kenya leadership to advance our new agenda, the health security and sovereignty, you know, resilient systems for member states, financing, making sure that we manufacture drugs and vaccines and medical countermeasures on the continent to reach universal health coverage. One of the issues this week was the integrated management of childhood illnesses 2026 perspective. DG call for urgent action on maternal and newborn health, stressing stronger systems and financing and innovation, science and innovation. Africa recorded 89 moderate and high risk public health events in 2026, with cholera and mpox remaining major outbreak burdens in DRC, and our DRC colleagues are doing a phenomenal work to deal with this situation. Measles remains a major concern there with 36,000 cases, 364 deaths. This is huge. We don't have pleasure reporting these numbers, but it is good to know the situation, that you find solution of how to deal with them. This is driven by displacements, overcrowdedness, conflict, and low vaccine coverage, according to our investigation there. Mpox. Madagascar, DRC, Kenya, Burundi accounted for 82% of confirmed cases now in the last 6 weeks. Confirmed Mpox cases declined from a peak weekly average of 1,000 in week 17 in 2025, and right now week 6 in 2026, and a 90% reduction on the continent. But MPOP has transitioned into routine health programs as ongoing, and member states are reporting that. However, let me sign the caveat: when there is community transmission, human-to-human transmission that is going on in a community, in a country, please ensure that the incident management system team continue to move there and find the cases, treat them, prevent people, trace the contacts, which used both measures in this situation. Medical countermeasures and public health countermeasures. If medical countermeasures and other things are not working and there is still community transmission, you want to make sure that we put all two together. That's the public health countermeasures, putting your contact tracers out there, making sure that incident management team is working, EOCs are stand up, and people are doing community engagement, social mobilization, and all of these things are good. Madagascar remains a major hotspot and leading the fractional dose vaccination going on. DRC is the largest cumulative contributor of 37,000 confirmed cases and 127 deaths. Cholera is a major issue this week. These are the things that we are highlighting right now. In 2026, Africa reported 25,000 cases, almost 26,000 cholera cases and 514 deaths across 14 member states, with a case fatality rate of 2%. Africa accounted for 59% of global cholera cases. So this is a serious issue that our member states will have to deal with. 99% of global cholera deaths in 2026. DRC and Mozambique, as my colleague Yab was reporting, the details contributed about 83% and 86% of deaths in Africa. Kenya, Sudan, Tanzania declared the end of cholera outbreak. Cheers to them. Yay, good news for declaring an end to the outbreak. We want to share the good news as well as those that are doing well and making progress. At the same time, continue to monitor the situation, because that's how we are not blindfolded and we can respond. Rwanda and Zimbabwe reported new outbreaks. Our team is following very closely, monitoring the thresholds of how we can respond. Major drivers still remain flooding, displacement, poor water and sanitation and hygiene conditions, unsafe water, sanitation gaps, and weak health systems. We want to thank you for listening. We want to thank you for tuning in. Next week, our team are working, those that are in the background, collecting, collating, analyzing, and reporting this data. We want to make sure our people on the continent are safe. This is what Africa CDC is about. Safe continent, safeguarding the lives of our people, honor the leadership of His Excellency Dr. Jean Kashey, our Director General, and members of the team. Thank you.
Thank you, Director.
Thank you, Director Talbot. Thank you, Prof, for a very comprehensive highlights of health incidents on the continent. At this juncture, we're going to transition into receiving questions from our media colleagues and the team here, Director Talbot, Professor Yap, and other experts on the call are going to be providing responses to your questions. So we'll begin with on the live Zoom section where we have two of our colleagues who have already raised their hands. We will start with Janice Quay from Bloomberg. Janice, the floor is yours. Janice, can you hear us? Go ahead.
Yeah, I can hear you. I just needed to be unmuted. Can you hear me now?
Yes, I can hear you. Go ahead, please.
Super. Thank you so much. I found that slide really useful and interesting about the new US bilateral deals. And I understand that the funds now go directly to the African governments, and this is what Africa CDC had proposed because it pressured these member states into increasing domestic funding. But can you please comment on three things? The implications for continental health governance and whether bilateral deals weaken or strengthen the regional coordination mechanisms. Number two, how is Africa CDC ensuring that there's no economic blackmail like what's been reported in Zimbabwe and Zambia? And also, how is Africa CDC insisting on equity and benefit sharing when it comes to data?
Thank you, Janice. Those are three loaded questions, so I will allow the panelists to respond. Maybe we can begin with the director and then Professor Yap can add. Director, over to you.
So thank you. That's very great questions, Jenny. The thing is we promote sovereignty, number one, and the DG has stressed that over and over again, that countries should be able to make the decision, and this is what the agenda is about: health security and sovereignty of our member states. However, bilateral relationship should not weaken regional collaborations because through the regions are better up to support countries in that. And equity, because once you have these pathogens and there's an outbreak, the communication, the deals should be negotiated based on what benefit sharing that the countries get. So we should not blackmail countries because they are pushing for the equity, transparency, and accountability. Thank you.
Professor Yap, do you want to add? Do we move on, sir?
No, we can move to the next one.
Thank you. Thank you, Director, for the response. Our next colleague is Rachel Abuja from the Nigeria's News Agency. Rachel, you have the floor.
Thank you so very much, directors, and thank you for the opportunity to ask my question. Still on the bilateral relationship, I don't know if the director from Liberia has actually read some of the MOU being signed. I say this because I read the one for Nigeria, and if we must own our sovereignty as the DG said, how do we go about retaining our sovereignty over our pathogens, over our health data, and the scientific benefit attached to it? And I also like to know how many African countries have actually, or how many African countries have consistently pay or use their budget, the 15% Abuja Declaration budget. They've retained that and they've been consistent in doing that. Because the last time I checked, the countries that actually paid for or for their 15% budget are very few compared to what we have today. So I think it's something that the continent are confused about, and they truly want African CDC to speak on this and simplify this message for them to the best of their knowledge so that we don't pass the wrong message. Thank you, and over.
Thank you, Janice. Over to you, Director. I think those are two questions, three questions.
Yeah, yes, great. I think when DG had his interview, he was very clear. Instead of going into country specifics, because countries should be given the leverage to make decisions for their citizens and their benefits. Recently, Zimbabwe and Zambia denounced unbalanced agreements in Zambia health deal that tied to mineral sector's concession. And Africa CDC was very clear that if Zambia and Zimbabwe demands, the DG demands the respect and sovereignty decision-making and no economic blackmail, as he said. He was very clear about that. In as much we support countries as well as we are engaging with our partners, the United States, that have been supporting a lot of work on the African continent, government to government with the America First agenda, that we ourselves are negotiating diplomatically to see how these can benefit countries. And partners must now aligned with Africa's agenda and not reverse the agenda. So countries should be able to negotiate. We preach equity, we preach transparency. Africa CDC preach that countries should have the leeway and the leverage to engage their partners. If you refuse not to sign a deal and you have a strong justification based on your sovereignty, Africa CDC supports that. At the same time, if you know very well that the deals work for you, we also are open to that, but it should not be, it should be on a win-win situation. And data sharing, pathogens deals should benefit the countries that own those pathogens. Thank you.
Thank you, Director. Prof. Yap,
Yes.
do you want me? Okay.
Yes, there was the follow-up question on the Abuja declaration and the few number of countries. I think we are talking about Rwanda, Botswana, and Zambia. Those are the countries that currently have reached or exceeded the 50% target. And then you recall, we start by talking about DRC, and next week you will also have the opportunity to hear from the DG and from the Minister of Health in DRC how they are managing to reach the 15% with 14.2%. And this is happening. This is happening with the support of Africa CDC, deploying more than 20 finance experts going to work in the Ministry of Health, and there will be the interface between the health and the finance, ensuring that they work on the inefficiencies that are happening in the system, and also taking all the opportunity to have more efficiency in the management of their funding. And that will allow the country to invest more. Going back to DRC, you remember this figure, $800 million every year was because of the ghost worker. So now, strengthening the digitalization of the workforce will definitely allow the country to recover that money and therefore invest it in using it as a domestic financing. So this is what is happening, and we believe that with the expert that we are pushing, but also the advocacy at the highest level, we'll be able to see more and more of our countries in the continent achieving the Abuja target. Over to you, Nick.
Thank you, Prof, for the responses. You and Director, of course. So just to notify the panel, we had a long presentation section. So I will appealing for the benefit of our media colleagues, question to be asked. We will extend the section at least with an extra 10 minutes of your time, if that meets the indulgence of the panel. Thank you very much, Director. So let's now proceed to the chats here. I think a lot have been said around the bilateral agreement. I think our first two colleagues have ask questions around that, and responses have been provided. So I will move to the next question from our colleague Tomori. Tomori asks, what is the current situation on the suspended Guinea-Bissau hepatitis B vaccine trial? Just Prof and Director, before you come in, let me add a second question to that. And this second question comes from our colleague Zodide, who is from the Chinese news agency. Zodide asks, which health emergencies are currently the most critical across the African continent, and what specific indicators are driving that assessment by Africa CDC? So those are two questions from Tomori and Zodide. Over to you, Director and Prof.
I think the Guinea-Bissau one, our colleague, Dr. Fala is on the line, the Director for Science and Research. Maybe you have some insight about what's going on in Guinea-Bissau. Dr. Fala? Hello, Prof.
Dr.
Yes.
Fala, are you with us? While we are waiting Dr. Fala to get connected, maybe the second question, we can take it on the assessment and the emergencies that are happening. Over.
Yes, but actually, on the first question, there is nothing new since the last time that we've talked about the trial with the message that we get from Guinea-Bissau. Now, the second question on the indicator, I will ask Dr. Mercy, who's connected, to emphasize on the indicator that are used at our surveillance level to highlight the different health emergency in the continent.
Dr. Mercy?
Yes, thank you. Can you hear me? Okay. Thank you so much, Prof, and good afternoon, colleagues. I think this is a very important question. So on the continent, we are currently plagued with several emergencies. As you must have heard from the previous presentation, you hear how cholera is spreading across several member states. And we also have diphtheria, we have measles, we have Lassa fever, quite a number of them. But what helps us to be able to categorize and assess and categorize our public health threats? Three main factors, and we're looking at the context, the hazard and exposure. By the hazard, we're looking at what are we dealing with, for instance, the pathogen that we're working with. An example could be cholera. Do we know cholera? Yes, we do know. Do we have diagnostics for cholera? Yes. Do we know the particular genotype we're dealing with? Yes. So we have to ask those questions. Is this novel? Is this something that we know? Is this something that we have countermeasures for and all that? The second bit is the context in which it's happening. Definitely we see so many different countries experiencing environmental hazards. We're looking at so many countries having cholera in the context of cyclones, flooding, poor watch infrastructure and all that. So that also keeps us at a very unstable situation. So the way we're going to grade cholera in a country like, say, in the northern part of the DRC will be completely different from the way we're going to assess cholera in an area, say, Kinshasa, or the way we are going to grade cholera in Cameroon, say in Douala, might be different from the way we're going to grade it in Yaoundé. So because the different contexts in which it's occurring are quite different, or the way we're going to look at it in a refugee camp, where in an area where it's also plagued by humanitarian crisis, completely different. So those are some of the indices that we look at, and also the exposure. Where we've had preventive vaccination, and maybe there's cholera being detected in a particular community, different from the way we look at cholera in an area where there's been no preventive vaccination, there's been no immunity stirred up in those different areas. So we look at these different factors, and beyond that, we have a number of critical questions that we also are able to answer. Lastly, there are situations especially during outbreaks that span beyond just the main outbreak space, that we're looking at the public health situation analysis, that which goes beyond just affecting the population, but goes into the intricacies of the health system, affects access to primary health care and all those. So we are going to assess that differently, and that will also require a different initiative and different strategies in the response. I hope I was able to answer to your question. Over.
Thank you. Director, you want to complement?
No, I think it was excellent.
Thank you.
Thank you, Director. Thank you, Dr. Mercy. Let's go back to our chat. Our colleague Ayede Addis from the News Africa News China is asking. He says, how is the incident management support team prioritizing limited resources with multiple outbreaks occurring simultaneously across different parts of the continent? And he says, what lessons has been learned from this situation, from past outbreaks, and how are those lessons been learned and applied? Those are two questions from our colleague Ayeli. I will move quickly to the next question on from the chat also. Peter Ledu, he asks, shifting from dependency to dignity requires a robust ecosystem as we move towards the Africa Health Security and Sovereignty Agenda or goals. How can Africa CDC better incentivize non-state public health institutes to lead in local manufacturing and R&D to reduce external dependencies? So those are three questions actually that to the panel. I think we can start from the last question with Director, and then Prof and the rest of the panelists can complement. Over.
So shifting from dependency, recently Africa CDC, led by our DG, called private sector and non-governmental actors, including governmental actors, pharmaceutical industry for local manufacturing on the continent. And I think that was exciting and incredible to see private sector actors coming together, manufacturers and all of them coming together to see how Africa, because I believe the data shows that only 1% of vaccines produced on the African continent. If I'm quoted right, I know that that's correct. So we're trying to shift from this, from bringing, products, vaccines, therapeutics, diagnostics. Our research team is also working to put mechanisms in place to do this. Quite recently, we put in place a pool procurement system, that manufacturing system, local manufacturing system on the African continent, to make sure that in the next decade or so, that trajectory can change. At least 40% of what we use here can be produced here. And it's working through not state actors, not only government, but the private sector and the pharmaceutical industries. There are countries that are doing well in this area. We must congratulate the Senegal, the Ghana, I think Morocco and other countries, South Africa, that are making efforts to promote local manufacturing on the continent. And that's one of the flagship projects for the Africa CDC's Global Health Security and Sovereignty Agenda. Thank you.
Thank you, Director. We'll move over for the question on the IMST to Prof and the team. Over to you.
That's the co-chair. He's the right person.
Thank you so much, Director. This is a critical question, and you remember saying that 2 weeks ago we were in Kinshasa with all our partners reviewing the performance of the IMST. What have we learned? We've learned that we've been able to work together, WHO, Africa CDC, and more than 28 partners. That was important. And working together has been an opportunity to really reduce the overlapping, especially at the time of the reduction of the ODA and the financial resources. The fact that we work as one team with one plan, one budget, and one M&E was really a great asset for us to mobilize the resource, but then to be able to respond to both Mpox and cholera. Now, what we've also learned is that the demand is increasing. You have seen, you have measles, which is also affecting many countries at the same time in the continent. A few weeks ago, or a few months ago, we were talking about diphtheria. So the demand is there. The demand is actually increasing as the resources are going down. So what we agree is to together have a new framework for the response of emergency in the continent and also include the preparedness. What we will be doing together is what we call the grading. So all together, we look at what are those emergencies that are occurring and see how together we can be the most efficient in responding. So are we going to include measles? Are we going to include diphtheria? And that will rely on what Dr. Messi mentioned. It will depend on the country capacity. It will depend on the availability of medical countermeasure. So all that process is happening and will be part of the framework that we'll be happy to present to you when it will be out there. Over to you, Nick.
Sorry, thank you, Prof. I think the extra 10 minutes I requested from the panelists is almost out. So sorry, colleagues, we're just going to take one last question from our colleague, Inas Villa from the Market Access, and then we're going to wrap up. So Inas asks around the Africa Epidemic Fund, and she wants to know, I would be very grateful if you could share any available details on the following areas regarding the Africa Epidemic Fund. One, the current size of the fund or its funding target. What are the current size of the fund or its funding target? Two, which countries or partners have contributed so far? Three, whether the fund has already been operationalized, or lastly, when it is expected to become fully operational. So those are a couple of questions around the Africa Epidemic Fund, and that will be wrapping our section up. Over to you, Prof.
Yes, thank you. I will start and the director will complement. So the initial target was around 200 million, which was considered as catalytic, which can be rapidly deployable, because let us remember that this fund is to allow the deployment within 48 hours of the epidemiologists, all the search together with the medical and non-medical countermeasures, so that we can follow the 717 where country can respond within the time, and we can control the outbreak at the source. So far, we've been highlighting some countries, Angola, that have been contributed, and many others. But the support we are providing to member states on domestic financing, as we'll be seeing next week with DRC, those funds mobilized will actually allow the country now to invest in the effort, because the priority of a country is to ensure that they have their own management of the public health emergency. So by working on inefficiency, by increasing the allowance of money on health, they will have more leverage to support Africa CDC and the Epidemiologic Fund, knowing that this is coming from the African Union. Therefore, most of the country will be following up. But I know that the director also have some perspective to add on what I've mentioned. Over to Director Tolman.
Yeah, I think you provided sufficient. That this is all I can say is so important that the African epidemic funds, we advocate with African countries to make sure that we put resources in our part. That should be a pool fund that support African countries for us to really be a sovereign continent. Thank you.
Thank you, Prof. Thank you, Director. Colleagues, thanks for your questions and all of the engagement today. With this, we come to the end of our session today. But as you know, I don't close it, but the principals do. So I will start with Prof. Yap, and Director Yensua will close the section officially. Prof, over to you, and after Director will close up.
Yes, once again, we welcome our director of our news center. It was a great pleasure to have you for this press briefing. And then we thank all the journalists, but also the scientists, all the public health experts that are following us either live or later on, to ensure that they have the right information, but also that they make us accountable. Thank you.
Over to you, Director, for the wrap-up.
So thank you. Let me wrap up like this. And I will make it like a quote from the DG of Africa CDC, His Excellency Dr. Jean Cashier. Mpox, COVID-19, Ebola, Marburg, proof pandemics and epidemics cannot be managed by bilateral deals alone. Epidemics have no border. And he continued to say, bilateral cooperation is good. However, regional approach is better. And partners must now align with Africa's agenda, not the reverse, unquote. Thank you, colleagues, for listening. And this is the end. Thank you. Congratulations.
Recording.